Fundamentally, we have to listen to the voice of the patients. We have to create an organization where we have the majority of people working with us who seek out actively, who put processes in place to collect the voice of the patient.
Hi, I'm Chris Malone, and I'll be your host for today's discussion. Today, we'll be talking with Dr. Doug Salvador from Baystate Health in Western Massachusetts. Doug wears a number of hats, and his titles include Senior Vice President and Chief Quality Officer for Baystate Health, Chief Medical Officer for Baystate Medical Center, and Professor of Medicine at the University of Massachusetts Medical School. Welcome to the program, Dr. Salvador.
Thanks, Chris. I'm glad to be here.
So to get us started, can you tell us a bit about Baystate Health and your roles there?
Baystate Health is a small to medium-sized integrated health system in Western Massachusetts. There are 4 hospitals, a multi-specialty practice group with about 750 physicians, 400 advanced practice professionals, a regional health plan, a home health agency, hospice, and a large captive multi-line insurance company. We have a medical school within a medical school program with the University of Massachusetts Chan Medical School, about 275 Baystate residents and fellows, about 13,000 employees, students and trainees in nursing and every allied health field. I've been here at Baystate for 10 years, and I currently hold the titles of Chief Quality Officer for the system and Chief Medical Officer at our Academic Tertiary Care Center in Springfield.
Wow. So you've got quite an impressive background and have studied extensively in public health and patient safety. I'm wondering, is there a story you can share about how you chose a career in healthcare and the journey that ultimately led to you to this work you're doing now?
Sure. Thanks for asking about my background. So, first generation American, I grew up son of a concrete construction laborer and a homemaker on Long Island, and ultimately went to college to be a engineer. And I was on a PhD engineering track until I sort of decided that I wanted the instant gratification of seeing patients one by one. So I ended up in med school, and when I got there, I was immediately enamored with the diagnostic process. The best diagnosticians in the hospital were the infectious disease docs, and that's who I wanted to be. It was also an incredibly exciting time. New HIV medications were coming on the market. We were seeing patients literally rise from the grave who had previously had been given death sentences. So I continued on and did my infectious disease training after internal medicine residency, and I was on an HIV clinical trials path. And that's really when I again looked at what the future could hold. I was very interested in science and epidemiology and data, and I took an MPH course in quality and patient safety, and kind of the lights went on. It was, okay, I can use the scientific method, generate hypotheses, collect data, test them out. But now we're making care better tomorrow and next week, not enrolling patients in a trial for 3 years and analyzing the data and hopefully publishing something that'll improve patients' outcomes. And that bug that I caught, that so many others have in quality and patient safety, has really led me to the observations that the thing that harms the most patients the most severely is really diagnostic error. And I've committed a lot of my career since then to trying to build systems to improve diagnosis.
Wow. So that's a remarkable journey. So given all of that, and from your perspective, kind of in the broadest sense, what do you think are some of the biggest challenges facing healthcare today? Is it diagnostic issues like you mentioned, or are there other things as well?
Lots of challenges, Chris. One of the most acute challenges I think we feel in the health system today is that we just simply are not meeting or cannot meet the needs of our patients and communities. We ascribe that to staffing, we ascribe it to increased need, we ascribe it to disconnections and fragmentation of the system. But at the end of the day, we're not able to meet the needs of our patients and communities. And that's a massive, massive challenge for all of us. I think that I would categorize one of the big challenges is the incentive system. What I see over the last several years is nonprofit health systems getting a shrinking pie of reimbursement to care for the sort of sickest and maybe the most resource intensive group of patients. And I think that contributes to that first one. And so we see the proliferation of for-profit and venture capital funded physician groups, payviders, others that are taking more and more of the care. I'm not trying to be political at all. I'm just saying that if you're in that nonprofit health system world, our incentive is really to look more like those for-profit organizations, and the organization that decides to invest more heavily in patient safety really is going to lose that financial game in today's world. And I think that incentive system is really important for it to change, for us to really do things a lot better. I would categorize one of the large problems is that we're still very, very provider-centric in the healthcare world. That we talk a lot about patient-centeredness, but what I see are families and patients who are struggling to work around our schedules, our rules, the system we've set up. And so we've just not yet been able to become flexible enough to kind of bend to the needs of our patients and families and communities. And then I don't think you can put a list together of challenges out there today without including health equity, that this is just this massive, before now, underground problem that we haven't understood, that we haven't admitted, that we haven't worked on. And the more we dig into it, the more we find really unacceptable conditions that we have to change. And in fact, we can't achieve the outcomes we're learning without addressing health equity head on. And that's a massive challenge.
Yeah, no question about it. No question about it. Now, I also understand that in addition to your other responsibilities, you also have oversight of patient experience at Baystate. I'm wondering how you're thinking about connecting the patient experience with the kind of outcomes and other challenges that you just mentioned.
So that's a new thing for me this year. Previously, the Division of Healthcare Quality, which I oversee, really had the patient safety, the quality, the infection control, the med staff, medical affairs kinds of functions within it. And I was not, I didn't have primary oversight for patient experience. So I'm learning. I've not had that in my portfolio in the past. I obviously have been in healthcare for a long time, as you know, so I have opinions. But I would say that I don't have a fully formed vision yet. But I do think there are certain things that observations I've made, beliefs I have. I think this issue of trust that you talk about and have studied and speak about so eloquently, have written about, is core and central to what we need to do differently. I think that we dabble, and we'll talk more about this, I'm sure, in trust building structures and trust building activities and trust building relationships, but we're not systematically creating that, and that's not the design that we have in place right now. And there's lots of reasons for that, but I think the idea of how do we think about reliably delivering a patient experience in a more similar way to the way we think about reliably delivering a patient safety prevention bundle, and including those accountability structures, including the principles of change management, and how do we inspire more people to be willing to get out of the comfort zone of our provider-centric world and to become more flexible. And then how do we create structures and supports and systems around them to make that possible for them to do, and not so extraordinarily difficult that we burn everyone out in 5 minutes.
Right. Well, that was going to be the second part of my question, which is how do we address building trust with the care team as well? And so that it's a two-way street, not just one that is looking at the patient side of the equation.
I don't want to pretend I have, the answers there, or to get preachy. It is rough, right? So times when I get frustrated are when, I hear leaders in the organization who have non-clinical departments who talk about, their good leadership and the way things are going. And, my knee-jerk response is, well, you don't have employees who are being spit on, kicked at, insulted, abused as a weekly and a daily course of work when they come in. I think that it's really difficult that, that there's what I've seen over the last several years, much more of a staff versus patients dynamic in certain areas that, really just can't be there if we're going to achieve this promise. If we're going to get to that patient experience, we've got to figure out a way to understand each other better, manage those behaviors better, be able to flip that dynamic from what it is. I don't have all the answers, but I do think we've got to tackle that and work on that if we're going to be successful in creating an experience where people are going to want to come to work, they're going to feel protected and safe at work, feel like they can do their best work, because we don't have that right now.
Got it. So Doug, after we finish our conversation today, I'm thinking I'll send you a survey about your experience in this discussion and ask how that worked out for you. Is that going to be a helpful way for us to improve? What's your thought on the degree to which we're asking both patients and care team members for feedback on a continuous basis like this?
Again, I'm learning, and I'm learning from you and your colleagues and others that I've been talking to this year, which has confirmed for me that we're just measuring the wrong things right today. That has come about maybe the most clearly in CG caps in the outpatient world, where we've got these physician ratings that are skewed to the right, and we've got we're harassing people to get from 93% to 96%, which there's evidence that shows may actually result in people delivering worse care. And so that's sort of the highlight example that exists in the world today. But I think, as I've learned from you and others, when we just measure transactional kind of feelings about one transaction after the other, we're missing out on perhaps the essence of a relationship, perhaps the essence of what people want caregivers and a healthcare organization to be for them.
No, I think it's a great observation. And your point about transactional versus relationship oriented, I think is really the point. I think all the evidence that we've seen suggests that patients really do want to have a relationship with their primary care providers and specialists and so forth. But so much of what has become the norm in healthcare is so much more transaction related. And that is kind of really watering down those relationships. But in our earlier conversations, I learned about the care program that you created at Baystate, and I understand it's spreading successfully across the state. Can you tell us about that program and how it's making healthcare more human at Baystate?
So I didn't create it. It was here, and it was one of the attractors for me to come here. Okay. But I'm certainly a champion for it, and previously coming to Baystate, I was a champion for moving in that direction. So care for us means communication, apology, and resolution, and it's a CRP program. We really don't use the disclosure and apology kind of moniker anymore. It's too sort of narrow and doesn't really do justice to the fact that this is really all about the communication piece. And so, we're just, we've just had previous leaders, my predecessor Evan Benjamin chief among them, who started out with a implementation grant from HRQ along with Beth Israel Deaconess Medical Center in our state. They set out to put in place a new program with some process steps that was designed to look at every case every time when patients have an unexpected outcome, when families are dissatisfied with their care, have questions about the quality of care that happened, whether errors occurred, and we would review them. We would immediately reach out to those family members, have a liaison from our patient relations department, let them know that we're reviewing the case, and we come back to them with a conversation. In the research study, over 3 years, over 1,000 cases that were reviewed in these 2 medical centers, additionally to community hospitals affiliated with them. What we really saw was that it was about 12% of those cases that fit into the category. Our definition of the care received didn't meet the standard of care, was not reasonable, and that gap caused harm. When that happened, we had a protocol for apologizing, for answering questions that patients and families had, and then entering into an early resolution process where appropriate, if that's what families wanted. And then we also looked at alternative ways to engage that patient and family in being part of the solution. We owed them, what are we doing about this so this doesn't happen again to someone else? And so we've been doing that for 10 years. And the initial people who started the study created what was initially called Macrame, a statewide collaborative with support from the Hospital Association, the medical societies, some insurers, and very early on included the plaintiffs' attorneys from these law firms that did this work. And so over that 10 years, we've created resources together. We've created a list of lawyers who are willing to engage in this process as opposed to the traditional malpractice process. And we've really got a commitment that's growing. A couple of years ago, I'm currently the co-chair of that statewide collaborative, which has turned into an advisory group under our quasi-governmental Betsy Lehman Center for Patient Safety in the state of Massachusetts. And we're approaching that tipping point for us of 50% of the hospitals in the state signing on to these processes. If you're in it and you participate in the collaborative, you are required to submit data on the number of cases and resolutions. We share comparative data within the collaborative, and we do trainings for new organizations. And we're on a mission really to get every single healthcare provider in the state of Massachusetts to use this method. We're not alone. There are hundreds of hospitals in the country who are using this, but the current reality is the vast majority of hospitals might say they're using an apology and disclosure program, but most of the time when we look under the hood, it's the obvious cases when patients and everyone else knew that there was an error that caused harm where they fall on their sword and apologize and potentially do early compensation. It's not the cases where we might be doing our usual reviews within the hospital. We find out we did something wrong when no one knew about it. Then we pick up the phone and call someone and say, hey, we need to talk to you about the care of your loved one. And then we admit and apologize the errors that we made. We've done that multiple times here. And that's that's a real program, every case, every time, collecting the data, putting the processes in place, and more places are committed to that.
That must really do a lot of good to not only building trust with patients, but rebuilding it with those whom it's been lost. And so with that as background, where do you think kind of designing human-centered systems to drive clinical excellence fits in? You kind of mentioned the phrase socio-technical systems in our discussions before. I was wondering if you could tell us a little bit more about that and whether that contributes to this process of improving quality and avoiding mistakes.
When people have asked me for the last 20 years, what's your job? My answer has typically been building learning systems, building the capacity within areas of healthcare systems where they have the leadership, the data, the improvement knowledge and capacity, and the culture to be able to identify the issues that are getting in the way of them giving great care to patients, and learning, asking the right questions, and improving and solving those problems. And I've carried the banner of creating those learning systems, carried the banner of patient safety in doing that, and that's because of my particular background. But ultimately, it's really about creating a highly functional, operationally sound, strongly led, evidence-based, and data-driven organization. And so we've talked about that so much in patient safety, right? In the quality world, we've talked about spreading capacity. We've talked about whole system quality. We've talked about safety systems that we want to put in place. But, at the end of the day, when we look at the results in the healthcare system that I work in and across the country, we've not achieved it. And so kind of why is that, and how do we sort of spread it? We're seeing more and more organizations with the financial pressures and the documented decrement in patient safety across the country during the pandemic recommit to systems like a daily management system, a high reliability organization model. And many groups do that in different ways. We're on that journey at Baystate Health, and we made a decision during the pandemic. It was really while we were staring the Omicron wave in the face coming at us, that we were going to move forward and not yet again say, oh, it's not the right time. And thus far, over a little bit less than 2 years, we've implemented a fairly typical daily management, lean type daily management system in 4 hospitals, and all the clinical areas, many of the non-clinical support areas, basically fully implemented in 2 years. These systems include tiered huddles at each of the areas twice a day, so that teams can stop and say, what's going to get in the way of us delivering good care today? What problems do we have that we can solve ourselves and need to work on? Which ones do we need to escalate somewhere else to get solutions for? And how did we do yesterday? And then in addition to that, we sort of have these escalating tiered huddles so that things that need to move up in the organization can very quickly. Those huddles are all associated with transparency, with boards or digital boards that describe the issues that are at play, describe current performance, and create an accountability structure, both for solving individual issues and for the overall performance scores that we have. And then in addition, we try and address some of the humanizing healthcare elements that you talk so much about through our leadership rounding, right? So we know from the work of Brian Sexton and Alan Frankel and others, and that, getting out there and delivering certain leadership behaviors when we're out there makes a huge difference in people feeling burnt out or feeling supported, or, so it's getting out there on a regular basis. We do that in pairs of leaders right after a tier 3 huddle on certain days of the week. And, we've had a training program so that we don't have people going out there trying to catch folks doing things wrong or telling them what to do, or feeling like they have to fix every problem that they hear immediately, but just being with people, getting to know them, understanding what are the real issues that happen to kind of flatten that sort of hierarchy. So we've successfully put that in place in our system in a way that has surprised me in how far we've come. There's lots of places that have put these systems in place, and I've been to a number of them where they haven't actually changed the outcomes. They're check the box exercises. People go out, people go to the meetings, they're not engaged. They don't engage the staff. They don't inspire the staff to deliver a different level of performance. We talk about the 2 projects for improvement that exist on every unit of every board in the system now. And many of those are experience type projects where we're following some data, and the goal here is reliability. We want to deliver the little things for every patient every day on every shift, because that's really the hallmark of clinical excellence. And so using those accountability structures, the measurement tools, to really focus on, are we delivering a great patient experience? Everything from, on this unit, our goal is when there's a behavioral issue and a patient's agitated or abusive or aggressive, we're going to institute some basic quality improvement and follow-up systems around huddling afterwards, about asking the questions, did we de-escalate in the way we were trained, and did it work, and what can we do better, potentially including patients in a debriefing so we hear their viewpoint in those instances, and getting that information up on the board and engaging people and saying that we can do better. How do we inspire some of the frontline folks to be champions for doing that through a structure like that addresses kind of not just a technical process, but includes those other socio-technical elements such as leadership and culture and really the interface with technology as well.
Wow, you've got a lot of really great stuff going on. It's really impressive. What are some of the things that have you most excited right now, of all the things that you are either leading, working on, or see going on in the environment?
We don't have the results we want to have, right? The key to all of this is really never being satisfied, but we're not doing well. As I said, the starting point was we're not meeting the needs of our community. I'm excited in this daily management system work because I'm starting to see the engagement that was missing so much in the pandemic. I've contended for most of my career that the antidote to burnout in physicians is really quality improvement work. That when you feel isolated, you feel like you're out of control and you're just being told what to do and you've got too much work to do, and it doesn't feel worth it. What I've seen change that around is being part of an interdisciplinary team where you've got other people working with you to solve a problem, where you have some time set aside to actually control your environment, change the process, and that you're following data that tells you, and you can see clearly, look, I'm delivering better care now. That's what I've seen take, a mid-career doc who was ready to hang up the stethoscope and then turn around and like coming to work again. And so we've just recently done our, over the summer, our immediate post-implementation employee engagement survey and cultural safety survey through our vendor Press Ganey. And we've been able to see that despite us having, poor overall engagement scores as it relates to the rest of the country, we're getting closer to the 50th percentile when you compare us to the Northeast, hospitals, but we're still not, a leader there. But if you look at the questions this year that ask, do you have a voice here? Do your ideas matter? And do you get recognized? We're in the 70th percentile, and that's a far cry from where we were a year ago. And that's part of what this system was designed to do. And so when I go out and watch a tier 1 huddle and I see 5 night nurses rushing to share a good catch or share a recognition of one of their colleagues or call out an issue that needs to be escalated, that's getting in the way of giving them, then I know we're on the right track and we're getting there. And we're also starting to see in pockets of the organization some real shifts in things like pressure injury rates. I see on the call right now is our nursing director of our medical ICUs, Jonathan Recchi, and his area using the daily management system has produced reductions in pressure injuries that I haven't seen in 10 years here. And so starting to see some of the outcome changes is giving me a lot of hope.
That's terrific. So given what you've seen so far, what advice would you offer to other leaders who are working to improve patient experience, staff engagement, clinical quality? Are there any principles or starting points that you would suggest?
I think that this whole system transformation is the holy grail for everybody who's trying to do quality improvement, patient safety, patient experience work. And I've been at this type of work for 20 years. And this is the first time I feel like we actually have a shot at doing that system-wide transformation. Many of the people on the call, many others doing this kind of work have successfully done this in pockets in an OR and a cath lab and an endocrinology clinic and a primary care practice. But to really do it across the board is what I think holds the promise for us to really shift the dynamic and deliver the care we want to deliver. And to do that, people talk a lot about the leadership that's necessary. And I think one of the fortunate things for me is I was in a position 2.5 years ago where we had a leadership team that was completely aligned and said, we're going to do this, and declared to the organization, we're going to do this across the whole organization. And I've not been in an organization as part of a leadership team that was willing to do that. And that was some of the magic of the pandemic and how we all reacted and worked together during it. And now as we built momentum, it feels like that's difficult to stop, and that's part of the excitement. But I do think there needs to be that kind of leadership commitment, and there are ways that you and others can work to build that up to demonstrate to others that it's a hard commitment to make, but it's worth it. And then just support the heck out of the teams when you start so that they can be successful.
Thank you. That's helpful. Now let's take a few questions from those listening remotely. Question for Dr. Mike Woodruff. He says, thanks for the great discussion. You mentioned the imperative for health organizations to get more flexible to meet parents, families, and communities where they need to be met. How do organizations make this a leadership priority?
It's hard. I've often thought, and now that I have some ownership, I've often thought what we need to do is we need to take our biggest conference room and we need to put all of the senior leaders of the organization on the stage and invite the entire community and give them microphones to the community and tell the leaders that we're not allowed to speak for the next 3 hours and just listen. And I think that fundamentally we have to listen to the voice of the patients. We have to create an organization where we have the majority of people working with us who seek out actively, who put processes in place to collect the voice of the patient. And we struggle with that. And we have more commitment and we work towards meeting those needs. And coming out of the pandemic, we've heard from nurses who say, do we have to go, back to having visitor hours be wide open again, right? So some people who felt like they were more efficient and got through their work of the day without patients and families, we know that's dangerous, right? We saw how many patients got harmed because they didn't have their loved ones and advocates there with them. So we've got to figure out a way to demonstrate the value of listening to the voice of patients to every single person. And again, I think about it in the same way as the patient safety improvement project or the quality improvement project. We've got to inject reliability. We've got to inspire folks. We've got to create champions, and we've got to demonstrate that it works. Because I those of us on the call really believe that it does.
Yeah. You mentioned the importance of involvement of patient and families. I'm wondering, where do patient and family advisory councils come in? Do you think they play a role in facilitating some of this in addition to the individual feedback?
We've got to have a omni-channel or a multi-channel or multiple ways to listen to the voice of the patients. I think that as I've talked to people, I'm growing in my belief that it's not going to be this, monolithic PFAC that makes decisions creates input for a whole organization, but it's going to be the birthing center PFAC that consists of birthing people who had their babies at that birthing center, who are going to be able to take that lived experience and provide, essential input on how to make it better. I'm more intrigued by sort of local use of patients who have experience in that particular condition or specialty or area, and whether we call them PFACs, whether we have sort of an ad hoc on-call group of advisors that we can reach out to, by virtual meeting like this, or because they meet every month, or because we invite them to come onto the unit and get involved in the care processes and talk to our patients and our staff. I think PFAC, in the way that many organizations create monolithic PFACs that I think too often get issues run in front of them for an up or down vote or an opinion that they don't really have the lived experience collectively to comment on. I worry that that's a very useful way to get the patient voice, but I think we're going to need lots of different ways to listen to the patient voice.
That certainly makes sense. Hey, I'm seeing a little bit more activity in the chat. It was asking about how do we incorporate provider wellness into all the strategies we've been talking about thus far.
Yeah, again, I don't have the answer. I have some ideas, and we're going to need to try to do that. Most organizations like us have grown provider wellness strategies and structures and leadership. We have provider wellness councils within our multi-specialty practice group. We have some interdisciplinary versions. We have some nursing centered and specific things that we're doing for wellness. Ultimately, one message I wanted to leave the group with today was really about integrating these pieces, right? So a comprehensive patient safety program has to have peer support as part of it, right? So we have a robust support system within our insurance company so that when a physician has a claim against them and starting that process, another physician who's been through that in the past gets paired with them as a mentor. On the floors, we have a robust peer support program that not only delivers individual peer support, but also group debriefings and group support activities after a bad outcome, an emotional case, whatever support folks need. And then, I've often said, we do root cause analysis when something goes wrong, and we close the door and we make this big disclaimer, everything in here stays in here, but that's not true, right? Those two people sitting next to each other have to go work tomorrow on the same shift with patients, and they're going to remember what somebody said in the room if we don't support them, right? And so when you think about what a provider wellness program provides, what a peer support program provides that's administered by a patient safety group, what the transparency and the rounding support from leadership can provide to people who are struggling through day-to-day issues, what the escalation process where problems actually get owned by leaders who have the ability to fix them, and we hold ourselves accountable to doing that, can do for sort of people. And then, you include the patients in that loop and start to understand we've got patients who are having experiences that aren't what we'd want them to have. Are we going to listen to them? Are we going to hold ourselves accountable together with them for changing that environment, changing the experience? I think we have to figure out how to incorporate all these things into one large system that works better than the one we have.
Well, that brings us to my favorite final question, which is, do you have a favorite quote? And if so, what is it and why?
I am a continuous quality improvement guy, and I have one quote that I've kept with me really since residency, and it's right up hanging on my desk here, and I'll just read it. It's entitled "A Little Courage. A great deal of talent is lost in the world for want of a little courage. Every day sends to their graves obscure men and women whom timidity prevented from making a first effort, who, had they been induced to begin, would in all probability have gone to great lengths in the career of fame. The fact is that to do anything in the world worth doing, we must not stand back shivering and think of the cold and danger, but jump in and scramble through as best we can."
Outstanding. Dr. Salvador, we can't thank you enough for spending time with us today. It's inspiring to hear what's been happening at Baystate Health and how you are making an impact in the world. We look forward to hearing more about your progress in the future. To our listeners today, thank you for joining us. We hope you found our discussion informative and inspiring. Be sure to join us for our next Humanizing Healthcare discussion. We'll be talking to Doug Johnson, Patient Experience Officer at North Shore Elmhurst Health. You won't want to miss it.